It's a pleasure to be with you. The title of this talk is Introduction to Worldview and Public Health, Session 1. There are no disclosures for this presentation. Objectives include understand how worldview impacts cultural distance, understand that a majority of people have strong supernatural beliefs that can be used to change risky behaviors. Describe the basic beliefs of naturalism, monotheism, tribal cultures, monism, and traditional Chinese cultures. Understand the benefits and challenges of the concept of primary prevention with different cultural worldviews. Review a few examples of how religiosity impacts healthy behaviors. Review key results of a SWOT survey of faith-based leaders. Describe the importance of horizontal communicators. Discuss the importance of addressing perceived needs in faith-based engagement. Discuss the importance of first dealing with spiritual fatalism before engagement, and review leadership skills for faith-based engagement. There are 7 dimensions that define cultural distance. The more one culture, culture X, differs from another culture, Y, in these 7 dimensions defines the cultural distance between them. Those 7 dimensions include worldview, or deep beliefs that inform the way a culture perceives the world, cognitive processes, or ways of thinking, linguistic forms, or ways of expressing ideas, behavioral patterns, or ways of acting, social structures, or ways of interacting, media influence, or ways of channeling messages, and motivational resources, or ways of deciding. The core of religion rests in the area of worldview or deep beliefs. Those deep beliefs influence the other 6 dimensions of cultural distance. Worldview not only influences the other dimensions of cultural distance, but also sets the base for a culture's values, the things they identify as important, their institutions, the way they organize, and eventually their behaviors and artifacts. Worldview beliefs are extremely important in influencing behaviors, including those associated with health and wellness. This talk focuses on some basic concepts of worldview as it relates to major worldview and religious beliefs. 81% of the world's population are adherents to religious organizations. In other words, 4 out of every 5 people on earth have beliefs in the supernatural. These beliefs in the supernatural may provide a powerful venue for public health to network with faith-based organizations to change risky behaviors. This slide lists Pew Research data from 2015 on world religious adherence. Christianity was the major world religion, representing 31.2% of religious adherents, followed by Islam at 24.1%, Hinduism at 15.1%, Buddhism at 6.9%, other or unaffiliated at 16.8%, folk religions at 5.7%, and Judaism at 0.2%. Monotheism, which includes Christianity, Islam, and Judaism, represents 55.5% of the world's religious adherents, followed by monism, including Hinduism and Buddhism, at 22%, and folk, other or unaffiliated, including tribal religions and traditional Chinese worldviews, etc., at 22.5%. This slide is also from Pew Research data, estimating the growth of religious adherent groups based on estimated births from 2015 to 2060. Islam will grow at the fastest rate, with a population estimated to increase by 70%, followed by Christianity at 34%, Hindu monism by about 27%, Judaism at 15%, folk, others, or unaffiliated religions at 8%, and Buddhist monism decreasing by 7%. Muslim women have the highest birth rate per woman at 2.9, followed by Christianity at 2.6 children per woman. All worldviews are likely comprised of 4 overarching categories of beliefs, including beliefs regarding human beings, listed as man in this diagram, beliefs of nature, beliefs of the supernatural, and beliefs of time, past, present, and future. These 4 belief categories encompass aggregates or groups of beliefs defining cultural ideology or philosophy of life, cosmology, how the universe was formed, etc. These worldview beliefs are deeply ingrained in every culture in the world. Every culture and subculture, including the public health culture, believes that the way they think, feel, and believe is the way to think, feel, and believe, which often leads to cross-cultural judgment. This can, if not understood and appropriately addressed, result in intolerance of others and can drive a wedge between public health professionals and those they are trying to reach. Using this construct, we can attempt to diagram several dominant worldviews, which helps understand how these various worldviews potentially impact approaches to public health and how this understanding can inform public health strategies. In this talk, we will consider the naturalist, tribal, monotheistic, monistic, and traditional Chinese worldviews. Realize that each worldview can be further divided into multiple sects, each associated with a unique set of core beliefs. This diagram represents the naturalist worldview, relating to many Western groups, including the general worldview of traditional science. An interesting observation, many naturalist cultures transitioned from a previous monotheistic, primarily Christian worldview. Naturalism is generally materialistic. In this worldview, the supernatural is commonly discarded or dismissed, often considered a mystical relic of a less developed or less enlightened period. Nature is regarded as a hospitable habitat for humans if left unchanged. Humans are in many ways like all other creatures, yet have a special, unique niche to fill due to their superior intelligence and reasoning. This worldview led to several prominent philosophies, including Darwinism, believing that the scientific method holds the promise of yielding an ethic that will free people who are good from habits that are bad and guide people into a new and hopeful future. Marxism and Leninism, believing that the hopes of man are based on certain select groups of individuals, leaders, destined to guide the masses to a better communal existence. Nietzsche, who disdained all who put trust in religion and intellectual approaches to human problems, thus willing to invest all authority in men of action who would command morality. Freud, who distrusted man as lazy and unintelligent and looked to select groups of scientists to chart a path into a bright future. All of these philosophies or aggregated beliefs stem from the naturalist worldview. This diagram represents the general worldview of many scientists, including those in public health. This diagram represents the naturalist adult worldview of time. The size of each circle represents the importance of each aspect of time, the past, the present, and the future. To most naturalists, History is somewhat important in forming and providing information to improve how things are done in the present. The future is very important. The present circle is also relatively large since decisions made in the present impact the future. In this worldview, with a large future circle, primary prevention, a major mission of public health, makes sense. Doing something in the present to impact the future. For example, exercise and an adequate diet in the present can impact a better cardiovascular system and lead to a longer, active life in the future. Other worldviews perceive time differently. This is a diagram of the monotheistic worldview of Islam, Judaism, and Christianity, representing 55.5% of the world's religious adherents. These are not the only monotheistic religions. The supernature, humans, and nature are separate and distinct. This worldview believes that God created the universe, nature, and humans not as an extension of his own essence, but out of nothing. God is and has been active in the world. God spoke to and continues to speak to people through divine inspiration. Examples would include individuals like Muhammad, Moses, Isaiah, Peter, Paul, etc., whose divine inspiration was recorded in books like the Quran, Torah, and Bible. Attributes of God can be seen in nature and humans that he created and were initially perfect. Satan enticed humans to rebel or sin, severing their personal relationship with God, requiring a plan of redemption to bring humans back into a right relationship with their Creator. Humans have been given a free will to choose redemption or not. Yet there are dire, eternal consequences for the unredeemed, including an eternity separated from God. The sin humans committed in the Garden of Eden eventually infected all of God's creation, resulting in rebellion, hatred, disease, death, and destruction. A major point is that monotheism believes that unredeemed humans are not basically good, but rebellious, different from the traditional Chinese worldview we'll discuss in a few minutes. There are some major differences in the plans of redemption between Judaism, Islam, and Christianity. In Judaism, redemption is related to sacrifices and the performance of rules and rituals. In traditional Islam, redemption relates to obedience to Allah's directives. A Muslim must take personal responsibility for the 5 pillars of Islam, including 1. The profession of faith, 2. The recital of ritual prayers 5 times a day facing Mecca, 3. The giving of alms, 4. The observance of the fast of Ramadan, and 5. A pilgrimage to Mecca. Christianity's redemption plan relates to Christ's sacrifice on the cross. In some Christian groups, the focus is on grace or unmerited favor for redemption. In others, the observance of rituals and rules are an important part of man's redemption. In the monotheistic worldview, humans have been given authority from God for stewardship over nature to appropriately control and manage it. I would like to compare the worldviews of time in Western monotheistic cultures for adults and youth. These diagrams are an oversimplification and obviously don't apply to all Western monotheistic cultures or individuals. To many Western monotheistic adult cultures, their worldview of time is similar to that of the naturalist. The future is very important, and to monotheists like Christian, Muslim, or Jewish cultures, is even endless or eternal. In this worldview, as with the naturalist worldview, primary prevention should make sense, doing something in the present to impact the future. The current youth culture in the United States would draw the present circle large with smaller past and future circles. Youth are not just young adults. They have a different worldview of time as well as other deep beliefs essentially a subculture within the monotheistic culture. Youth are concerned about relationships, being together, identifying with their peer group, events, and enjoying the present. Monotheistic adherent youth will likely identify with a larger future circle versus non-adherents due to their beliefs regarding eternity, yet the present is still extremely important. For Western youths, public health strategies that focus on present benefits will likely be more effective than primarily emphasizing the future. This is how a traditional tribal or folk worldview might be diagrammed. First, let's define what is meant by the word tribe. A tribe is not necessarily a group of people of common stock living in primitive or nomadic circumstances. Cultural specialists may define tribe as a people group having a unique set of ethnic beliefs or worldview. In this worldview, the sacred secular distinction is often blurred or eliminated, diagrammed with no delineation lines between humans, nature, and the supernatural. This worldview brings humans, nature, and the supernatural together in a curious amalgam. They're separate, but at the same time mixed. Wallace defined the tribal worldview as humans united with nature and the supernatural. This is an important worldview, representing 5.7% of the world's religious adherents. Many tribal cultures would draw their time circles as shown here. Once again, this is an oversimplification and doesn't represent all tribal cultures or age group differences in tribal cultures. The past and present circles are larger and more important than the future. Many tribal cultures emphasize the importance of ancestors. The concept of eternity may often be described as how well one is remembered by those that follow. Messages about actions and behaviors that will enhance legacy with family members and the tribal community may resonate more than an emphasis on personal future benefits that may have more impact on Western adult monotheistic cultures as previously described. Let's now consider monism that represents 22% of the world's religious adherents. Monism is a form of pantheism, mostly associated with Eastern religions. Pantheism is a doctrine which identifies God with the universe or regards the universe as a manifestation of God. In this worldview, the supernature, or God, nature, and man or humans are all one unified reality. A behavior that reflects monistic beliefs is the common greeting of hands in a prayer position, recognizing the divine, a manifestation of God, within the person being greeted. Monism believes that what people physically see and experience is not reality. One must move into pure consciousness or superconsciousness to find true reality. Monistics obtain a state of superconsciousness or true reality through meditation techniques. This monistic belief that what is experienced in this life is not reality creates a challenge for public health strategies regarding primary prevention or interventions, since the situations observed, for example, environmental contaminations, are not really real, therefore are not a priority to address. Time is cyclical in monism, as diagrammed by the perpetual circles, an endless cycle of reincarnations or transmigrations. A primary goal of monism is to move from bad karma that binds humanity to the universe and the incarnation cycle to a state of emptiness, void, or bliss, exiting the endless cycles of reincarnation. This goal, to reach a state of bliss, called Brahman in Hinduism or Nirvana in Buddhism. So the goal is not immortality or even prolonged life, since in monism they already have that in the endless, tiring cycle of incarnation. These beliefs can impact the effectiveness of Western public health messages and programs that promise prolonged life. Let's now consider the traditional Chinese worldview for a few minutes, which are included as part of the other unaffiliated or folk religious group representing 22.5% of the world's religious adherents. This worldview is quite complex. I hope this discussion and diagrams will help understand these beliefs. Chinese tradition utilizes 4 terms that relate to God and evil spirits: Shangti, Jian, Shen, and Kuai. Shangti is a personal God who is supreme ruler over all earthly rulers. Chinese rulers worship Shangti at the altar of heaven in Beijing. Tian is the name for the impersonal heaven that can influence circumstances on this earth. All believers seek the help of Tian. Shen represents good spirits, like the gods of nature, wind and fire, and Kuai, evil spirits. There is an eternal order or pathway which relates to the destiny of humans and nature called the Tao. All beings and things evolve from the Tao. There are 3 types of Tao: Tian Tao, or the way of heaven or providence; Shen Tao, the way of gods; and Ren Tao, the way of man. Tao manifests in the competing principles of yin and yang. Yang represents positive elements: light, heat, masculinity, strength, life, heaven, and virtue. Yin, on the other hand, includes the opposite elements: darkness, cold, femininity, weakness, death, earth, and vice. Yin and yang impact the spirit world along with Shen as good spirits and Kuai as evil spirits. The spirits control all parts of nature. The intent is that humans should do nothing that would disturb the balance of these good and evil spirits in the world, called the feng shui. Any human action or project, for example, building a bridge, burying the dead, a wedding, business agreement, etc., should determine the impact on the feng shui and avoid anything that would cause a negative disturbance. It is the duty of a person to embrace the Tao, to hold to it, and thus control himself or herself and destiny. To do so is to practice Wu Wei, or non-action. It is to live spontaneously in accordance with nature, not desiring, forcing, or imposing one's will upon nature or other people. A good man, full of virtue, is dominated by Yang and will be a positive influence on the community. In contrast, a bad man, full of vice, would be dominated by Yin and thus be a negative influence. Traditional Chinese beliefs hold that people are basically good and remain good by following the Tao and also through education. This slide represents the cosmology or creation beliefs of the traditional Chinese worldview. According to some accounts, before creation, the universe was in chaos and was symbolized as an egg. After 18,000 years, the egg hatched, with Pan Ku's body emerging, filling the gulf between heaven, yang, and earth, yin. When Pan Ku died, his body became parts of the world. His head became the 4 cardinal mountains, his eyes the sun and moon, his hair the plants, and his flesh the rivers and sea. In the traditional Chinese worldview, humans and nature are inseparable. They have a common origin, following a course, Tao, in history and abide by the same laws. Some strategic public health approaches in this worldview could relate to the Tao, the pathway, the Yang, positive elements, the Tian, that influences circumstances on earth, the Shen, or good spirits, and Feng Shui, the idea of balance. As you might expect, it would be very difficult for an external public health person to appropriately interpret and engage these worldview beliefs. This would require the engagement of a respected person from the culture who understands and practices those beliefs to adequately contextualize the collaboration with public health. This is true of all faith-based, supernatural worldviews. A champion from the target culture is absolutely essential. These people are also known by many other titles, including horizontal communicators, opinion leaders, and influential individuals in class. This is a key community engagement concept and strategy. Let's consider a few examples demonstrating the importance of spiritual beliefs on health behaviors. This is from a study by Holt et al. Published in Cancer Control in 2005, a study of African American women from Alabama, St. Louis, and Kansas. 74% of these women identified with the Christian faith, with 11.8% having no religious group identification, 0.9% Muslim, 1.7% Jehovah's Witnesses, and 9.4% of unspecified affiliation. Women who engaged in religious behaviors and held strong religious beliefs consumed more fruits and vegetables associated with decreased cardiovascular disease, diabetes, and certain cancer risks. The reason for this association of religious beliefs with a healthier diet was unknown. Another study of white women from the Northwest did not show a similar association between religiosity and fruits and vegetable intake, but did show a positive association between religiosity and low-fat dietary behaviors. This is a study published in the Journal of Adolescent Health from 2006. It studied sexually inexperienced adolescents aged 12 to 14 years old and looked for the association between parent and family religiosity and the time of first sexual experiences and contraceptive use at first sex during the teen years. More frequent parental religious attendance and family religious activities were related to later timing of sexual initiation, but did not translate into improved contraceptive use. Once again, showing some association between faith beliefs and healthy behaviors. The main point of these studies is that spiritual or religious beliefs, at least for monotheistic religions, were associated with some healthy behaviors. Tapping into and engaging faith-based communities may be an important public health strategy. Due to the complexity of faith-based worldviews, along with subgroups and sects associated with major worldviews, it's often helpful to complete an open-ended SWOT analysis of faith-based leaders in a target area. SWOT stands for strengths, weaknesses, opportunities, and threats, or barriers and limitations. This slide lists 8 questions used in North Dakota in 2007 by the Healthy North Dakota Collaborative Program to gather key information regarding the impact of faith-based organizations' worldviews as expressed in their values, the way their organization functions, and ultimately the resultant behaviors as related to engagement with public health programs. Those 8 questions included: what are your general thoughts regarding your group's role in public health programs? What are the strengths for your group's engagement in public health programs? What are the weaknesses for your group's engagement in public health programs? What are the opportunities for your group's engagement in public health programs? What are the barriers or limitations for your group's engagement in public health programs? What are the next steps, if any, to engage with public health programs? What is your interest in working on a faith-based task force to improve risky behaviors? And is there any additional information or comments you would like to add? I was particularly interested in answers to questions 4, 5, 6, and 7 regarding opportunities, barriers, next steps, and interest in engaging in a task force. The next few slides lists some key results from that survey related to implementation of a collaborative between faith-based organizations and public health. Question 4. What are the opportunities for your group's engagement in public health programs? Aggregated responses included: help members get more involved in community outreach. Could be of interest to young faith-based leaders who seem more interested in creative outreach. Encourage faith-based leaders to be better role models of health. Could work better in rural faith-based communities. Help meet the strategic mission of the organization. Could help public health impact, since faith-based leaders and organizations have much more respect than public health. Build interfaith trust and collaborative outreach, and help meet the physical needs of members. What are the barriers or limitations for your group's engagement in public health programs? Lack of member interest, belief that spiritual outreach is much more important than improving physical health, distrust of government, inadequate resources, time, finances, and personnel, doctrinal differences with other faith-based groups, skepticism of collaboration with outsiders, fear of people with physical and mental problems, liability, and several large faith-based groups already have health and social outreaches and feel further collaboration would be duplicative. What are the next steps, if any, to engage with public health programs? Convince faith-based leaders of the value of public health programs in helping to accomplish their mission. A respected theologian addressing this issue would be essential. The governor, not just public health officials, would need to invite faith-based leaders to participate. Develop a collaboration that focuses on activities, not just discussion. Incorporate this concept in the formal theological training of faith-based leaders, training of participating members. Integrate these programs in the strategic plan of the organization and include healthcare organizations in the collaborative. What is your interest in working on a faith-based task force to improve risky behaviors? Several expressed interest in working in a task force. Surveys like this can help give insight into the beliefs and values of faith-based groups and inform approaches to collaboration efforts. So, a main goal is to decrease the cultural distance between cultures, like in this diagram between culture 1 and culture 2. These two cultures need to have enough common ground, trust, and respect to work together collaboratively toward common health goals. Public health needs to identify appropriate ways to craft programs considering the 7 dimensions listed here. Worldview is of major importance for faith-based groups and can have a major influence on program effectiveness. So how can public health efficiently decrease cultural distance with faith-based groups that have a different worldview from theirs? This slide lists 2 general strategies to decrease the cultural distance between different worldviews. Cultural immersion of public health personnel in the faith-based culture is possible, but generally takes time, months to years, if ever, to accomplish. This obviously doesn't fit well with most grant or program schedules. A more efficient route is to facilitate and engage respected individuals, formal and informal leaders from the faith-based organization, utilizing community engagement techniques to address their group's problems and solutions. Informal community leaders are known by several names, including peer leaders, horizontal communicators, champions, influential individuals in class, opinion leaders, etc. These individuals are already enculturated, since they live in that faith-based culture. Appropriately engaging these formal and informal leaders from the community invokes the formula, same culture equals same worldview equals appropriate contextualization of messages and programs. It's not only important to identify and engage formal and informal leaders, horizontal communicators, in the faith-based community, but those leaders must also identify with the public health messages or programs to be effective. NIDA identified 4 levels of identification with the message, including, first, no interest in a personal change of behavior or becoming a messenger to others. Second, interest in a temporary personal change of behavior, but no interest in becoming a messenger to others. Third, interest in a permanent change of personal behavior, but no interest in becoming a messenger to others. Fourth, interest in a permanent change of personal behavior and interest in becoming a messenger to others. Many public health professionals feel that current programs generally engage people and communities at levels 1 and 2 and rarely at levels 3 and 4. Faith-based leaders must identify with the message or program at the 4th level or nothing will happen. They won't be leaders or messengers of the public health program in their community. So how do we move formal and informal faith-based leaders to the 4th level of message identification? Faith-based leaders will engage in programs and projects they perceive as important. These perceived needs may or may not reflect the real needs as perceived by a public health community engagement facilitator or other external experts. Yet these are the issues the community will own and address. Community engagement is facilitating a process of problem solving, not a project. It's facilitating a faith-based community to own their problems and solutions, not an external perception of their problems. From my experience, engaged communities will eventually address the needs perceived by external experts, but within their priority and time frame, not necessarily mine. This approach will often challenge a community engagement facilitator who would prioritize needs differently, often based on their own personal or professional worldview or deep beliefs and values. Patience to move at the pace of the faith-based community is essential for true community engagement. Community engagement facilitators help faith-based communities identify and prioritize their perceived needs by utilizing a variety of nominal group processes and techniques like snow cards, road to health, etc. Have you ever met someone or a group of people who feel that no matter what is done, nothing will or can change? How easy was it to work with a group like that on issues regarding change or community engagement? Likely very difficult, if not impossible. This attitude or belief that things can't be changed is called fatalism. There is a spiritual fatalism in some faith-based groups, though fortunately rare. Engagement, community change, and development cannot take place in the face of significant fatalism. Fatalism says, my fathers had these problems, I have them, and my children will have them. There is nothing I can do to change things. These things are ordained by God. It's totally in God's hands. Fatalism must be addressed by the faith-based community before being engaged. This work often rests with the spiritual leader of the group. This slide is a hunger task force report from San Joaquin County in California from 2007. The task force was composed of healthcare institutions, health insurance providers, nonprofit organizations, governmental agencies, and multiple faith-based organizations. The focus was on food deserts, food education, and food access. Task force goals included food stamp outreach, an information campaign, increased food supply to food banks, nutrition education, farmers markets, legislative advocacy, nutrition, food management, and food safety classes, and hunger awareness events. This obviously met the worldview beliefs, resultant values, institutions, and behaviors of the participating faith-based groups. Someone has to facilitate these collaborations. Public health at the state and local levels are well positioned to do this. This is a list of skills public health leaders should possess for faith-based engagement, including community engagement facilitation skills, facilitating faith-based organizations in a process of problem solving. Community engagement also requires exceptional patience to move at the pace of the faith-based community. Cultural diversity and cross-cultural communication skills to appropriately collaborate with organizations that have different worldviews or deep beliefs. Adaptive leadership skills to help groups address complex problems, and coalition building skills. This slide summarizes some key thoughts on approaching faith-based communities. Supernatural beliefs of faith-based worldviews are complex, but must be understood to adequately engage a faith-based group. Utilize SWOT, strengths, weaknesses, opportunities, and threats, open-ended survey questions to gather information about how faith-based worldviews in a target area will manifest at the institutional and behavioral level regarding public health engagement. Utilize community engagement techniques to effectively engage faith-based communities. Application of the community engagement concepts of facilitation of a process of problem solving, engaging formal and informal faith-based leaders, and dealing with the perceived needs of the community are key. Develop integrated training curricula for theology training institutions. Utilize key leadership competencies for faith-based engagement, including community engagement facilitation, cultural diversity and cross-cultural communications, adaptive leadership, and coalition building skills.